Important safety information for Aggrastat, tirofiban hydrochloride injection. Indication: Aggrastat is indicated to reduce the rate of thrombotic cardiovascular events, defined as combined endpoint of death, myocardial infarction, or refractory ischemia, repeat cardiac procedure in patients with non-ST elevation acute coronary syndrome. Contraindications of Aggrastat include a known hypersensitivity to any component of Aggrastat, a history of thrombocytopenia with prior exposure to Aggrastat, those with active internal bleeding or a history of bleeding diathesis, major surgical procedure, or severe physical trauma within the previous month. Warnings and precautions. Aggrastat can cause serious bleeding. Most bleeding associated with Aggrastat occurs at the arterial access site for cardiac catheterization. Minimize the use of traumatic or potentially traumatic procedures, such as arterial and venous punctures, intramuscular injections, nasotracheal intubations, etc. Concomitant use of fibrinolytics, anticoagulants, and antiplatelet drugs increases the risk of bleeding. If bleeding cannot be controlled, discontinue Aggrastat. Thrombocytopenia, discontinue Aggrastat and heparin. Bleeding is the most commonly reported adverse reaction. For additional information about Aggrastat, please refer to the full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
Hi everyone, my name is Dr. Saihari Sadanandan. I'm the Director of Tampa Cardiovascular Interventions and Research. I'm an interventional cardiologist with more than 20 years of experience, and I work at St. Joseph's Main Hospital, St. Joseph's Hospital North, and Advent Health Carrollwood Hospital in Tampa, Florida, as an interventional cardiologist. So today I'm here to present my case using Aggrastat in acute coronary syndromes in a patient who received no dual antiplatelet therapy pre-procedure. So this is a patient coming in with an ACS, de novo, and they are taken for an urgent cath. What would we do in that situation? So the purpose of this video is to demonstrate a typical use of Aggrastat for fellows and those who may not be familiar with contemporary use of 2B3 inhibitors. Well, here are my disclosures. I have to concede I received financial support from Medicure for creation of this video. And Medicure is the company that manufactures Aggrastat or tirofiban. So here we have a 64-year-old male with hypertension, diabetes, and hyperlipidemia. He presents with typical worsening of chest pain over the last 3 days. He presents to the ER, and in the ER, they do an EKG, and the EKG shows non-specific ST changes in the inferior leads and a loss of R-wave voltage identified in the precordial leads. So they send off a series of troponins, and the first troponin was elevated at 0.1, which is distinctly abnormal at our institution. Given its classical symptoms and the troponin elevation, a diagnosis of non-ST segment elevation acute coronary syndrome was made. He was treated with our standard protocol of IV heparin, aspirin, nitroglycerin. Given his blood pressure, he was received a beta blocker. With the initiation of treatment, the patient became pain-free, and he was admitted to the hospital with a plan for an urgent cardiac catheterization the next day. And in this instance, it turned out to be next day, late morning, which was about 16 hours after presentation to the ER. So the next set of slides, you will see what we saw on angiography. So the patient had a right dominant system. His left main coronary artery, as you see, was patent, but he did have what appeared to be a subacute occlusion of a large OM branch of the left circumflex with semi-zero flow, with collaterals reconstituting the distal portion. The RCA appeared to have a 70% proximal and 50% diffuse distal stenosis. There was further diffuse disease in the RPDA and RPL, but all of them with symmetry flow. The LAD had only mild to moderate disease with TIMI-3 flow, and overall, his LV ejection fraction on contrast left ventriculography was normal. Before we get into the description of the next steps, here is a short refresher of what is Aggrastat or tirofiban. It is a reversible antagonist of fibrinogen that binds to the glycoprotein 2B3A receptor. It blocks the final common pathway to platelet aggregation. It has about a 2-hour half-life, and then platelets then slowly return to normal function by about 4 to 8 hours after the cessation of the infusion. Aggrastat provides very potent and rapid platelet aggregation inhibition, and has a very consistent response across various patient population and patients. Most importantly, through its mechanism of action, Aggrastat at that dose has the ability to disaggregate an existing thrombus, which neither an anticoagulant like heparin or a P2Y12 inhibitor can do. Now, there are limitations to what thrombus it can disaggregate. Typically, it disaggregates well a freshly formed thrombus. Back to our case now. Here is how we decided to proceed. We realized the patient received only aspirin, and he had a subacute total occlusion of his large left circumflex OM branch, which was the culprit. This was a too high-risk situation to deal with only with heparin as an anticoagulant in the absence of dual antiplatelet therapy with adequate preload. So we decide to administer a bolus of Aggrastat, 25 micrograms per kilogram, which is a standard dose. And following the bolus administration, along with heparin, with an adequate guide support, the lesion was then crossed with a Asahi run-through wire. Distal intraluminal location was confirmed. The lesion was then pre-dilated with a balloon, establishing TIMI-3 flow, following which the lesion was stented with biotronic drug-eluting stent. An infusion of 0.15 micrograms per kg per minute of Aggrastat was maintained for the duration of the PCI to allow for the loading dose of clopidogrel to take effect, which was given at the end of the procedure, after the procedure in the cath lab. A 600 milligrams of clopidogrel was administered post-PCI. The patient was then sent to the recovery area. Aggrastat infusion was stopped in the cath lab. Patient was recovered in the recovery area and was sent to the floor. And then he was discharged home the next day on clopidogrel 75 milligram once a day and aspirin 81 milligram once a day. The patient had an uneventful post-operative or perioperative course and was discharged home successfully with no complications. So here are some takeaways from this case. It is common to have patients present with acute coronary syndrome and not be on dual antiplatelet therapy. So they may come to the cath lab on only aspirin, and you may have a complex thrombotic lesion. Aggrastat can be used in patients with no DAP3 procedure to be able to cover the patient during this early window of vulnerability. In this case, the treatment of the locally formed thrombus, which was a subacute occlusion of the OM branch of left circumflex, was dealt with in this fashion. The Aggrastat then provided adequate antiplatelet therapy, while the oral agent was loaded to take effect subsequently. Aggrastat use facilitated a successful urgent PCI in a patient who was not on dual antiplatelet therapy. Thank you for watching, and if you have any questions, please reach out to the Aggrastat team for more information.